Yeah, good evening, one and all. So myself, Dr. Varma, working as head of the department, Yashoda Hospital, Malakpet. So I welcome you all for this webinar, uh, especially on current trends, which is going in the present scenario. So today topic for discussion is AHA updates of 2020. So registration is one of the most important critical aspect when we are dealing with any patients, like in emergency or critical care, wherever it is. So there are many recent guidelines, recent updates. So what we are going to discuss today. So for which we have two respected faculties. One is Dr. Rajkumar. He is regional faculty for AHA. Then second one is Dr. Suresh Kumar. So who is our TC coordinator and AHA faculty. So now we are going to discuss about recent updates of 2020 guidelines of registration. So now I welcome you, Dr. Rajkumar, to open up the session. So I hand over the mic to Dr. Rajkumar.
Yeah. Thank you, Dr. Kiran, sir. It's very nice to see you again at on Zoom finally. And it's always been a pleasure working with you and teaching alongside you. And I'm really thankful to Dr. Suresh for giving me this opportunity to speak here. If I can share my screen, just a moment. Yeah, sharing now. Can everybody see my screen?
Yes, we can.
Okay, right. So the topic I'm going to talk about today is something called Resuscitation Science. Now, before we start, let me introduce myself. I'm Dr. Rajkumar Elanjeran. I'm a regional faculty appointee of American Heart Association. Before we start, let me declare that this is a voluntary appointment and I stand no conflicts of interest with the AHA or any other board. So resuscitation is a very complicated topic. It covers not just cardiac, it covers neuroprognostication and so many things. And I think AHA in 2020 has finally stepped forward from the cardiac science towards neuroprognostication. And that's what you will see in the guidelines as well. So I will not only talk about some important updates in the AHA science, but I'll also talk about how these updates came about. When you talk about American Heart Association, you have to understand how these science comes in, how these updates come in. So I'll talk about both these things, the science as well as how the science takes its origin. Dr. Suresh will cover many aspects of what the updates actually are. I'll just go through a brief overview of what the important updates are, where is the actual emphasis of AHA, and how this emphasis came about. So it's always been the same story. We want to emphasize on early rescuer CPR from bystanders. And that is something which is severely lacking in a country like India as well, right? We don't really see people taking up the challenge of doing CPR to lay rescuers. So we want to re-emphasize on lay rescuer CPR. The previous recommendations about epinephrine have been reaffirmed. We are focusing on early epinephrine administration, especially in non-shockable rhythms. I'll talk about epinephrine towards the end of my talk. It's a very controversial subject for many resuscitation experts, and I'll also explain why it's a controversial subject. Use of real-time audiovisual feedback device. Even when you teach a BLS class, we always focus on high-quality CPR. We don't want just CPR. We don't want students doing CPR or interns doing CPR just to declare a patient dead. We want CPR to be of the highest quality possible. And for that, we need adjuncts. We need objective adjuncts such as audiovisual feedback devices. We can use a normal metronome. You can download a simple app on your phone, which makes a clicking sound tick, tick, tick every 100 to 120 per minute. And that can be used as an adjunct for doing high quality CPR, right? We need to continuously monitor the quality of CPR as and when possible. If the patient is in a critical care unit with an arterial line in place, well and good, you can monitor the arterial blood pressure. But if you are intubating a patient and you have ETCO2 access, you should utilize ETCO2 for monitoring quality of CPR for ROSC achievement. IV access over IO access. This is an important change. Earlier in 2015 guidelines, we used to focus IV access and IO access almost on equal grounds, right? But now we are focusing a preference to IV access rather than IO access. We're not saying IO access is not recommended. We just prefer IV access better. ROSC, the endpoint of resuscitation, but it's not really an endpoint, is it? We all know getting a pulse back is such a big achievement, but our goal or our treatment does not stop there. We need to focus on oxygenation, blood pressure control, a plan for a PCI, early PCI if you don't have a reversible cause yet, target temperature management, and a new line, multimodal neuroprognostication. This is absolutely essential to understand ROSC outcomes because we have something called CPR downtime. How much time after the patient collapse was CPR actually started? If it's in the hospital, in an emergency unit or in a critical care unit, it might be a few minutes. But outside the hospital or in a ward area or a non-critical care area in a hospital, the downtime is going to be much longer, and more the downtime, worse are the neurological outcomes. Everything in CPR, everything in resuscitation centers on this, hinges on this particular point, neuroprognostication. What is the neurological outcome of the patient after a few months, especially after 3 months? That's our goal. Is the patient going to be bedridden, or is he going to be a valuable member of the society? How much medical care are we spending on this patient after 3 months of cardiac arrest? That is the end goal of resuscitation science, right? And that is the focus of resuscitation in 2020, right? So once a patient has had ROSC after cardiac arrest, and once you're planning a discharge, the approach to discharge of patient also has to be multimodal. They need physical, cognitive, and psychological, psychosocial assessment and psychosocial support as well. Remember, cardiac arrest is a traumatic experience, not just for the patient, but even for the healthcare workers. So it needs to have a proper debrief, and it needs to have proper psychosocial support from your colleagues as well as from your environment. The current cardiac arrest survival rates in India are less than 1%, right? Less than 1%, which means for every 1,000 patients that you do CPR, maybe one will survive, maybe one. That is a huge, one will survive to discharge. I mean, one will survive to discharge, not just getting ROSC, survival to discharge. That is a huge cognitive load on the doctor's mind, on the nurse's mind. You are likely losing 999 patients. That's a huge number. So they need emotional support. They don't need judgment from their peers. They don't need judgment from their bosses. Cardiac arrest is something we can't really control. So emotional support and recovery is the 6th link which was added in the chain of survival this year. We also focus on management of cardiac arrest and maternal resuscitation, focus on the maternal resuscitation, and also early perimortem cesarean delivery. That is the focus in cardiac arrest in mothers. Now we'll talk about some facts and some myths. So all of us understand that we're following the American heart association guidelines because they're very standardized, they're great guidelines. The videos are very good to look at. The books are very well published and all that. But let's not forget that these guidelines are not purely American. That's in fact one of the criticisms you find in senior emergency physicians, senior anesthesiologists. They say that, oh, no, these guidelines are from American guidelines. You can't use it in India and all that. That is utter nonsense. These guidelines are not made by an American board. Let's be very clear about that. For some of you who are already familiar with this, these guidelines are made by a society called the International Liaison for Committee on Resuscitation, fondly called ILCOR, ILCOR, International Liaison Committee on Resuscitation. These include voluntary members, voluntary doctors, and resuscitation experts from all over the world who gather together and meet to make sure the research is up to date. They go and study whatever research has been published. They do a systematic review of every paper that has been published in Resuscitation Science, and they recommend if these guidelines can actually be used or cannot be used. Okay, so they've been meeting since 1992 almost, and their member organizations are several resuscitation councils, namely the American Heart Association, the Heart and Stroke Foundation of Canada, the Inter-American Heart Association for South America, Australia and New Zealand Committee on Resuscitation, European Resuscitation Council, Resuscitation Council of Asia, Resuscitation Council of South Africa. So these are the member organizations of ILCOR. They volunteer and they send doctors and experts from their countries to meet together, to get together and study every research that has been published so far, right? In that particular year and that particular month. And they decide whether these guidelines are to be used or not. And these member organizations, ERC, AHA, all these organizations, they adopt these guidelines and they make videos out of it. They make books out of it. They publish it and they adapt it to their own country's needs, right? So what we are following is not AHA guidelines in a sense. We are following ILCOR guidelines. ILCOR guidelines, which are standardized for the worldwide, right? The only reason we probably use AHA is because it's better packaged. It looks really good. And, we always like something that looks good. So the ILCOR task forces, there's a task force for adult life support, for basic life support, for implementing and educating people on these guidelines, for first aid, for pediatric life support and neonatal life support. And we use the AHA guidelines, which has been reviewed, which has been categorized, and which has been prioritized in a particular way, which guidelines to use, which not to use. So ILCOR International Congress, AHA CPR ECC guidelines, and ECC training materials, which you all use and you all get certified on, right? So now that we spoke about the ILCOR guidelines, how does the AHA classify it into levels of evidence and class of recommendation, right? So AHA uses two systems, classes of recommendation and levels of evidence, to make sure that the guidelines are appropriate. We know that, okay, this is the correct guideline, this is not the correct guideline, which is useful, which is not useful, which is harmful. That's how they categorize it, right? First, classes of recommendation. Class 1, strong recommendation, which means benefits far outweigh the risks. These guidelines are recommended, they are indicated, they are useful, they are effective, right? Let me give you an example. Use of epinephrine in cardiac arrest. Yes, it is currently a class 1 recommendation, but it used to be a class 2B recommendation. I'll come to that later. It's currently a class 1 recommendation. Class 2A, moderate. Benefits outweigh the risk, but not by such a large margin as a class 1 one. These are reasonable interventions, can be useful, effective or beneficial. Class 2B, weak. Benefits slightly outweigh the risks, right? Usefulness or effectiveness is unknown, but logically it makes sense to use them. So class 3, no benefit, and class 3, harm, which means we don't use these. Let me give an example of class 3 harm, cricoid pressure. We know that cricoid pressure is harmful in resuscitation, right? So class 3, no benefit, many guidelines are there, right? So there are few guidelines which are very strongly recommended. There are a few guidelines which are not all recommended because they're harmful. So this is how AHA identifies and tags each recommendation. Mind you, AHA makes 491 recommendations. If you take BLS, ACLS, PALS, NALS, everything together, there are a total of 491 recommendations. And all these recommendations are published in the Circulation Journal. That's where you will get access to them. Circulation Journal, freely available, by the way, right? So which is within each guideline, within each of these 491 recommendations, there is a class of recommendation and there is something called a level of evidence. There's something called a level of evidence. What is the level of evidence? Was it a randomized control trial? Was it a non-randomized control trial? What was it? That's what HA talks about. Level A, at least one RCT. At least one RCT from more than one RCT. And these are all meta-analysis of these RCTs. Level B are one or more RCTs, meta-analysis of moderate quality RCTs. These are not high quality, moderate quality RCTs. Non-randomized, so these are registered studies, meta-analysis of these studies, observational studies, etc. Level C is observation. Level C, expert opinion. This is where there is no study at all. Expert opinion knows that this works, right? Because it's some aspects of resuscitation cannot be studied because it might be harmful for the patient himself. Example, we can talk about ECMO and dual sequence defibrillation, right? Dual sequence defibrillation is based on expert opinion. There's no RCT yet published on dual sequence defibrillation. So that's a expert opinion. So these are all the different levels of evidence. So two things, class of recommendations and levels of evidence. Every single evidence in AHA out of the 491 I told you about, 491 recommendations are tagged with a class of recommendation and a level of evidence both, right? But here's the hitch. We have 491 recommendations from the AHA. Only 1% are level of evidence A. Only 1% are from multiple RCTs with systematic reviews. That's a huge lacuna for research and that's a huge lacuna for evidence, which is why we keep telling you that the AHA guidelines keep changing. 10 years back, we were using atropine in cardiac arrest. We were sure atropine works in cardiac arrest. Now we know atropine does not work in cardiac arrest. 15 years back, the guidelines was ABC. We knew ABC works. We knew ABC is the right way to go. Now we're using CAB. So evidence changes, guidelines change. And it's up to us as resuscitation experts, as doctors to stay up to date. And AHA provides an excellent platform for us to stay up to date, right? So the ILCOR, we're talking about ILCOR for a minute, right? ILCOR, it uses something called COSTR, right? Comprehensive Observed Systematic Research Papers, right? They make COSTR recommendations every 5 years. We all know this, right? This is a fact versus myth story again. We all know that AHA used to make recommendations 5 years. And we know that the next update will be in 2020. Now it's 2020 because the new update. The next update will probably be in 2025. But that's not entirely true. Since 2015, the ILCOR has decided that we won't wait for 5 years anymore. Whenever a new recommendation comes, we will implement it, we will study it as and when and implement it if required, right? That's the new standard now. So the AHA has taken upon itself to study the evidence from ILCOR, to take the evidence from ILCOR and publish it into guidelines as and when required. So they'll make new videos, they'll make new training materials, they'll make something called interim training materials whenever there's a new update. Example I'll give you is 2018. The guidelines came out in 2015, but in 2018, there was a RCT published about lidocaine versus imidazole in cardiac arrest. They were both shown to be equally beneficial. And AHA sent an immediate update to all its instructors, to all its training centers, implement this. In classes, start teaching in ACLS that after third shock, you can either use lidocaine or imidazole equivalently. Both are of equal evidence. All right, so that's how it works now. We don't wait for 5 years anymore. Maybe the book publishing, the video publishing will take 5 years, but whenever there's a new guideline published in the science, whenever we know that there's a new guideline which is important, that guideline will come out to us immediately from ILCOR and through AHA. Okay, that's how it works. Some new aspects, some new concepts that the AHA has implemented right now. First, CPR Coach. You might think that already the teams are constrained. We have 6 team members. Each team member is doing one particular role. Already we are constrained. What is this new CPR Coach? CPR Coach is one of those team members itself. Example, the defibrillator, one of those team members itself, who takes it upon himself to ensure CPR quality is maintained, right? He can also give feedback about when to intubate, when to switch roles, etc. Right, along with the person who is making the recordings, who's noting down things. Right. So CPR coach is a new concept. His job is exclusively to ensure CPR quality is maintained at 100 to 120 per minute, push hard, push fast, adequate chest recoil, minimizing interruptions, giving effective ventilations. That is the job of a CPR coach. Hover. What is hover? So when you're doing CPR, after 30 compressions, you're going to interrupt to give 2 breaths, right? So when you're giving those 2 breaths, don't stand up and relax back. Just keep your hands a few millimeters or few centimeters above the patient's chest so that you can go back to CPR right away. Pulse pre-check. Remember, we check for pulse. All of us know this, who've done ACLS know this. We check for pulse every 2 minutes only when there is a organized rhythm, only when there's an organized rhythm, but we're changing it now because we almost all of you who've done a CPR on an actual patient fidget for the carotid pulse. We search for it. Where is the carotid pulse? I'm not able to find it. Where's the carotid pulse? I'm not able to find it. So what we do now is, before we analyze rhythm, at least 15 seconds before we analyze the rhythm, while CPR is going on, we start finding the pulse. We start finding the pulse. Excuse me. We start finding the pulse, right? And because CPR is going on, you'll be able to feel some pulsations while CPR is going on. So once you interrupt CPR, now we'll be able to tell for sure whether pulse is there or not. Got it? So you're doing a pulse pre-check 15 seconds before you analyze the rhythm, so that you know where the pulse location is exactly. That is the only purpose. Switching roles. Earlier, we used to recommend switching roles in a semicircular fashion, right? The airway person goes to the head end person comes back to the CPR, or the defibrillator person comes into compression. Now we are recommending that switching roles happen side by side. It's not so that they have lesser interference, but it's so that everybody has the same view of the scenario, right? We don't want people moving from one area to another in the scenario. It confuses them. There's a cognitive overload. They're seeing something there. They come back to this position, they're seeing something else. So we want them to stay in one position and have the same view of the disease scenario. We want people to stay in the same locations. All right. That's why we recommend switching roles side by side, so people have the same view of the scenario. Okay. These are the 4 new concepts that HA has included in ACLS training and BLS training. Coming to epinephrine, I'll close with this. I think I've already taken 15 minutes. Just give me 2 minutes. I'll close with talking about epinephrine. Epinephrine, a very, very controversial drug. If you don't think it's controversial, if you think epinephrine is a clear shot drug, it works for cardiac arrest, which means we haven't read the evidence yet, right? Why is epinephrine controversial? There's 2 ways of looking at epinephrine, a very unbiased view of looking at epinephrine. 1, epinephrine is going to cause cardiac stimulation, right? It's going to cause basically heart contraction. It helps in ROSC. We know that epinephrine helps in ROSC, and evidence has proven that as well, right? Over time, multiple RCTs have proven that epinephrine is better for ROSC compared to placebos. There's an RCT done in 2018 where they compared pre-hospital epinephrine and pre-hospital placebo, and it was proven that epinephrine improves ROSC. But the question is, does epinephrine improve survival to hospital discharge? Survival to hospital discharge, which means, does the patient come out of the hospital with an intact neurosensorium? Is he going to be a functioning human being after coming out of hospital? That is something that has not been established yet, because epinephrine causes severe vasoconstriction. We all know that, right? In the heart, that could be a good thing, but it also increases myocardial oxygen demand. That's a bad thing. In the brain, vasoconstriction is not a good thing, right? So epinephrine might help the heart, but might fry the brain. Okay, so when you're talking about epinephrine, you have to look at both aspects. We want the patient to survive, yes, but we also want the patient to survive with a good neurological outcome. Maybe it's asking for too much, but that is what matters, right? So epinephrine, we don't know yet whether epinephrine actually damages the brain, because the first dose of the first CPR, the first time to CPR, starting CPR is delayed in almost all scenarios. Nobody starts CPR immediately when the patient cardiac arrest, whether in the hospital or outside the hospital. So all these studies which have taken into account epinephrine and cardiac arrest, they all have significant downtime before epinephrine is actually given, before CPR is actually started. So we know that these patients, the brain is already damaged because of delayed CPR. Now they're giving epinephrine on top of it. We don't know whether the brain damage is because of delayed CPR only, or epinephrine is compounding it. So we don't really know what epinephrine does. But because epinephrine improves ROSC, because epinephrine makes sure the heart recovers, we elevated it from class 2B recommendation to class 1 recommendation. So take epinephrine with a pinch of salt. Okay, do not assume that epinephrine is the cornerstone of treating cardiac arrest patients. HA clearly says, right, give epinephrine in shockable rhythms when 1 or 2 deflation attempts are not successful, which means they're asking you to delay epinephrine only after the first or second deflation attempt. That is very, very clear. HA clearly says this. So don't assume epinephrine is the first choice. That is what we have ingrained in our minds for some reason. The moment patient has cardiac arrest, we go for starting CPR and we immediately give epinephrine. We don't even focus on defibrillation. No, analyze the rhythm. If it's a non-shockable rhythm, we recommend early epinephrine. If it's a shockable rhythm, shock first, wait, give epinephrine, right? Early epinephrine is not always a good measure, and that should be very, very clear to you. And we're definitely clear on the concept that epinephrine should be given only every 4 minutes, every alternate cycle, every 4 minutes, not earlier than that. So don't overload the patient with epinephrine. Don't give epinephrine whenever you don't have anything else to think about. That should not be your reflex. Epinephrine should not be your reflexive action, right? You should think about epinephrine only at the end of 4 minutes. Use your person who's recording for it. And I think that concludes my talk on resuscitation. Things to remember: stay current, always follow the updates, get yourself updated, get yourself certified. If you're not already certified, don't assume you know these things. Things change at the blink of a minute. Get yourself updated on resuscitation guidelines. And remember to follow the AHA guidelines in India. These are the current guidelines. These are the most up-to-date guidelines that we follow. So I recommend that you get certified in American Heart Association guidelines. Dr. Suresh, over to you.
Yeah. Rajkumar, that was a nice talk, Dr. Rajkumar.
Thank you, sir.
It was need of an hour. So regarding resuscitation sciences and all. So actually, there are many things what we learn in daily practice. So it is very much required. So it's like medicine is like a continuous process. We need to learn each and every day. So every day is a new point for you. Every day is a new chance to learn new things. Okay. So regarding our AHA 2020 guidelines. So previously what we used to practice 2015 guidelines. Now we are following 2020 because there are many updates. So it's been updated after doing many RCTs, many groundwork and all. So there are experts who give consensus on following updates. Okay, so that was a nice talk on resuscitation sciences, Asmar. Now I welcome upon Dr. Suresh. Suresh, over to you.
Yeah, thank you. Thank you, Dr. Varma, and a special thanks to Dr. Raj, who has come and who had gave his precious time to elaborate about the resuscitation science, how it was started, and what we are doing, and what is the future ahead. And coming to, it was a nice technical talk by Raj, and let's come on to the floor. What we are going to do, how, when, and where we need to implement these updated guidelines. Okay, just we are going to elaborate on you that. For introduction, I am Dr. Suresh, heading the emergency department at Yashoda Hospitals, Somajiguda, and I'm leading the HA programs as a training site coordinator for Yashoda group of hospitals, along with Dr. Varma. So most updated science, yes, 2020 AHA guidelines currently for CPR and emergency cardiovascular care, they deliver the latest resuscitation science updates, okay, for the highest quality of care as well as the improved outcomes. These are intended for lay rescuers initially, and then for training organizations as well as the healthcare professionals to implement the updated guidelines, how to save lives. Today topics are like we are going to touch on adult, basic and advanced life support, PALS of course, pediatric advanced and advanced life support. NALS we are going to touch a bit, neonatal life support and resuscitation education science, as well as the last phase is system of care. Coming to HS chain of survival, the sixth link has been added, that was the recovery is added. Why it has been added? You tend to see like after your resuscitation, after the running the code successfully, then again you need to think like those who are part of the code basically. So you need to think of what they are like. So after code again, they are in some trauma, like they have gone through the emotional phase, whether it is a rescuer or a patient, and then how to recover from those. There is a multimodal approach that we are going to discuss today. And there are enhanced algorithms and visual aids which provide easy to remember these. And then there is the importance of early initiation of CPR by lay rescuers. Again, it has been re-emphasized by AHA 2020 guidelines. And then despite recent gains, actually less than 40% of adults receive lay bus and rescue CPR. And again, fewer than 12% have an AED applied before EMS arrival. This is a very serious concern, actually, which emphasize to teach the lay rescuers as well as the healthcare professionals for AHA guidelines to save lives. Coming to early initiation of CPR by lay rescuers, 2020 updated guidelines recommend that you need to think that any patient is unresponsive, you need to presume that the patient is in cardiac arrest, if you don't do CPR, then it's going to harm the patient, and your again survival rate is very low. So coming to the old guidelines, like they said, like you need to check for pulse less than 10 seconds. But again, if you think like unresponsive, yes, patient is in cardiac arrest, please start CPR. Okay, please don't delay it. In the Western world, you see like there are so many cardiac arrest scenarios secondary to naloxone. This why naloxone? Opioid poisoning is very much common there. Like, and they tend to have a overdose, drug overdose, particularly opioids. So in this scenario, if you are a lay rescuer, yes, you need to assess the patient breathing whether normally or not. Just look for chest rise, okay, and then if breathing is breathing normally, then again you need to tap and shout. You need to activate your local emergency response system. You need to consider naloxone. Here, lay rescuers can give a shot of naloxone, which is there in the first aid kit available. With or when the EMS personnel available, you do have a naloxone. Just consider when the patient is breathing normally. Again, of course, patient is breathing not normally. He's having agonal breathing, or and then you are thinking like he might have the respiratory failure or arrest secondary to the opioid overdose. Yes, you give naloxone. Okay, use an AED, and please resume CPR if the patient is unresponsive until EMS arrives. Coming to healthcare providers, there is a little bit difference here. Yes, what is the difference here? Lay rescuers and then healthcare providers. Yes, you can check the pulse. Okay, you assume that patient is in cardiac arrest or not. Again, patient is breathing normally, is in a respiratory arrest. Please activate your emergency response system. Please consider naloxone and transport to the hospital. If you are a healthcare provider, already EMS arrived. Suppose yes, patient breathing not normal. Breathing is not normal, and then there is a less respiratory rate or shallow breathing, and then agonal breathing. Again, you need to start CPR as such, and then of course, if the patient is having pulse, then please open airway, reposition, okay, provide rescue breathing, and please give naloxone in this scenario. Suppose unresponsive, then patient is in cardiac arrest. Please consider naloxone. There might be another causes for the cardiac arrest. Just refer to cardiac arrest algorithm, and then please proceed. Coming to cardiac arrest algorithm, there is so much like what there among healthcare professionals. We always thought like, what is the new update? What is the new update? 2020 guidelines re-emphasize, okay, to give early epinephrine ASAP. Of course, you need, if it is a pulseless rhythm, yes. I mean, pulseless cardiac arrest, yes. There is a non-shockable rhythm. You need to give early epinephrine to increase the survival of the victim. Suppose there is a VF or VT, okay, without pulse, then what you're going to do? Again, early defibrillation is mandatory here, and then you need to give epinephrine after 2 shocks. What about lidocaine? Yes, it was there previously in the guidelines. Again, if your amiodarone is not available, again, you can give a lidocaine IV, initial dose of 1 to 1.5 mg per kilo, and then second dose, okay, you can give 0.5 to 0.75 mg per kilo, that is half of the initial dose. Again, previous recommendations about epinephrine administration. Again, it is recommended that early epinephrine administration is emphasized in the 2020 guidelines. Okay, and again, real-time audio AV feedback. It was mentioned in the 2015 guidelines. Again, it is re-emphasized that you need to rely on audio-visual feedback as well as ETCO2 monitoring to improve CPR quality and then for successful resuscitation. Of course, there is another thing. What is here? Double sequential defibrillation. Double sequential defibrillation is giving 2 shocks concomitantly or one immediately after another. Is it recommended? As such, most recent evidence, routine use of double sequential defibrillation is not recommended as per 2020 guidelines. As I said, early epinephrine, again, for a non-shockable rhythm, it is reasonable to administer as soon as possible. That is ASAP. Again, if it is a shockable rhythm, you need to administer after your initial defibrillation attempts, okay, after giving. And then again, IV access and IO access. What is your first choice? Of course, it is peripheral IV access, which is recommended as soon as the patient arrived to hospital or the EMS people arrived. It is reasonable to secure IV access, preferably peripheral. What about IO access? Yes, your initial peripheral IV access attempts failed. Yes, you can proceed for IO access. Of course, if it is IV access not readily available, yes, you can establish IO access. Again, real-time AV feedback and CPR quality. You can rely on ATCOT and AV feedback devices to assess your CPR quality. Again, debriefings and referral for follow-up for strengthening the emotional support for lay rescuers, EMS providers, as well as the hospital-based healthcare workers after cardiac arrest event will be beneficial. Coming to tachybrady arrhythmias. What about bradycardia algorithm? Initially, we used to give 0.5 mg, okay, 6 doses up to 3 mg. Now it has been stated that why to give 6 doses? You can cumulatively, you can start with 1 mg and you can go up to 3 mg. Dopamine dose has been changed from 2 to 20 microgram per kg per minute to 5 to 20 microgram per kg, per kg per minute, that you can titrate accordingly. Adult tachy with pulse, yes, you need to refer to the manufacturer guidelines. You need to refer to the manufacturer, like whatever the machine you have available, just refer to the specific recommended energy level. This is why. This is to maximize your first shock success. Coming to ROSC, yes, in the initial stabilization phase, always ROSC, we tend to stabilize in a ABCD manner. Yes, airway, it is secured, okay. We consider early placement of advanced airway, that is ET tube. Coming to breathing, so you need to start at 10 breaths per minute. This is a change, and then initially we taught you like SpO2 please maintain 94 above. Now again it has been a bit changed to 92 to 98. You need to maintain SATs between 92 to 98 after placement your advanced airway. Again, you need to maintain pneumocapnia, that is 35 to 45 mmHg. Again, hemodynamic parameters, that is related to circulation. Yeah, of course, you have taken the 12 lead ECG, then you need to maintain systolic blood pressure greater than 90. Just target map around greater than 65. Yes, you have achieved ROSC, patient is comatose. What you're going to do? Again, you need to just proceed for your targeted temperature management, that is 32 to 36 degrees for next 24 hours. Yes, obtain brain CT. Why? Yes, I need to rule out bleed, okay, and what causes the cardiac arrest, that I need to rule out. So obtain brain CT within 24 hours. Then EEG monitoring is recommended, and again you need to involve the critical care people, and then with the effective handover you need to shift to the critical care unit for the continuum of the care. Yes, what else? Continuously monitor the core temperature, preferably esophageal, rectal, or bladder, and then you always maintain normoxia, normocapnia, and euglycemia. Yes, of course, you do EEG monitoring, that will come across for the neuroprognostication post ROSC. And always you try to give the lung protective ventilation. This is the new entity which has been added in the 2020 guidelines. Yes, what I am going to do? Yes, I have shifted the case to critical care. Just that's not the end of the case. Just I need to follow up what exactly happened to the case. So we routinely in our ED we tend to follow up the ROS patients. What was the prognosis, and then how it went on. Then what is the patient now? Whether the patient was extubated or not, that we are going to see. So we can divide into initial 24 hours, 48 hours, and 72 hours. Yes, initial 24 hours, as I said, you need to get this head CT, okay? And then you need to maintain targeted temperature management. Post 24 hours, just you can maintain rewarming methods, but try to limit sedation and analgesia as possible, okay? Preferably avoid relaxants, and then control normothermia. And then you need to get the MRI, okay, just to see to assess the hypoxic brain damage. Electrophysiology, this is another thing. And 20 somatosensory electropotential. If they are bilateral, yes, exactly. So you're going to have the poor outcome. You need to see persistent status epilepticus and burst suppression in this. Another one, status myoclonus. This you can assess through the continuous EEG monitoring. Just after that, after 48 hours, you need to check for pupillary light reflex, quantitative pupillometry, as well as corneal reflex. Serum neurospecific analysis. Yes, if these are raising, yes, there is a concern that carries poor outcome. Recovery, again, you need to see for physical, neurological, cardiopulmonary, and cognitive impairment post ROSC or before the discharge from the hospital. We don't know how much time the patient came to hospital. So you need to calculate the time exactly, how much time was lagging behind for the initial CPR, initial CPR by EMS, or when you have started. Depending on that, your neuroprognostication vary. Yes, you need to have the comprehensive multidisciplinary discharge planning for patient for appropriate rehabilitative recommendations. And again, you need to for caregivers. What about us? Yes, we have gone through emotional trauma as well. Young patient coming to you, we don't know the cause, or polytrauma. You have done everything, and then again after that, you tend to hear the news like patient is not recovering well post 72 hours. Again, you feel like a bit depressed. Then here again, the debriefing will come into the picture. You need to, hospitals or any setups, you need to have the structured assessment for anxiety, depression, and post-traumatic stress and fatigue for cardiac arrest survivors as well as the healthcare professionals. Coming to special cases, scenarios, coming to pregnancy, yes, what we are going to do. Yes, of course, you have received the patient, your left lateral position, you have relieved the aortic, this one, caval compression, and then you have put it aside. Then, of course, the hypoxia is going to kill the pregnant patient, especially fetus too. So you need to perform airway management quickly. Okay, try to place the advanced airway at the earliest and administer 100% oxygen. Please avoid excessive ventilation again here. And you need to place IV line preferably above the diaphragm. And if receiving magnesium, please stop and give calcium chloride or gluconate, in fact. And then what about 5 minutes within arrival to ED, pregnant patient not achieving ROS? Yes, there is a concern again. There is a second life. So we need to perform, okay, immediate perimortem cesarean delivery. I think every emergency physician, okay, should be aware of how to do. Yes, we don't have a leisure or privilege of having gynecologist aside or obstetrician aside at every time. But I suggest everyone go to at least OT, and then when obstetrician is performing, unless he is just at least see what's of the structures which you are going to uh, open up the fetus. Okay, that you can do it with preferably with anesthetist and obstetrician aside. Okay, what are the potential etiological factors for the maternal cardiac arrest? Simply, I can remember it as A to H. This is a very simplified algorithm designed by HA, especially in the 2020 guidelines. So, anesthetic complications, yes, that is one thing. Bleeding, that related to trauma. Cardiovascular, okay, could be your eclampsia or something. And then drugs, of course, they tend to cause cardiac arrest as well as they affect the fetus. Embolic phenomena, yes, pregnancy, it is one of the risk factor. Fever, that could be due to anything that you need to see. General causes, of course, your 5H and 5Ts come into picture here, and then your hypertension. Pregnancy again, they tend to prone to more hypoxia, so you need to be aware of that. And am I going to monitor the fetus during resuscitation? Obviously not. If that is going to hamper your resuscitation efforts, please wait. Fetus to be continuously monitored for bradycardia post-ROSC, but not during resuscitation. What is new in 2020? Point of care ultrasound. Yes, ultrasound has a major role nowadays to detect the life-threatening emergencies. Quickly, again, if you see the 5H and 5Ts, again, there is a thrombotic phenomena, pericardial tamponade, and then you have a hemorrhagic shock. Quickly, just grab the ultrasound. You need to be familiar with your level 1 and level 2 skills. And if you're not, then catch hold of the senior. Quickly scan the chest and abdomen. You might find the reason. Just quickly try to correct it by involving the appropriate specialties. Yes, multiple modalities, okay, should be used to improve decision-making accuracy in case of neuroprognostication. Post-cardiac arrest care, yes, interventions again, ABCD approach. You need to stabilize in ABCD manner, okay, and then you need to continue management with the critical care support. Again, as I said, new link recovery has been added in the 2020 updated guidelines. Coming to ACS, there is no concept of STEMI and STEMI and unstable angina now. It simply modified it as ST elevation MI and non-ST elevation ACS. Of course, you have EMS, strong EMS, and then you're receiving a patient, 35 ml ACS, STEMI, and then already loading doses were given in by EMS people. Then what you're going to do? Please bypass ED. Okay, if your radiologist is readily available in cath lab, just simply go straight to cath lab. Okay, but try to accompany if his ABC is fine, and then quickly go to cath lab. Just bypass the ED. Stroke again the same scenario. If you have strong EMS and then you have confirmed stroke, and then please straight away go to the brain imaging instead of ED to save the time. Even if thrombolytic drug required, like if it is really indicated, just you can push the bolus dose in the CT room itself. Administer epinephrine, administer aspirin was removed. And what about endovascular therapy? We do have a window period of 4 hours, 6 hours, 12 hours, but now latest recommendations as per 2020 guidelines, okay, you can just think of endovascular therapy, okay, just involve your stroke core team, which involves which includes the interventional radiologist, okay, you can consider endovascular therapy up to 24 hours from the last known normal. And of course, alteplase and endovascular therapy, they both are recommended as per your setup as well as the patient condition. Quickly coming on to pulse, just I'm going to touch a few aspects. Initially, as you know, pediatric cardiac arrest, they tend to have secondary to hypoxia. So for that, you need to give more ventilations. Initially, it was one breath every 3 to 5 seconds. Now it was removed and it was changed to one breath every 2 to 3 seconds. That is, remember, it's 20 to 30 breaths per minute. Yes. What is your preference of airway management here? Better use cuff tubes with adequate cuff inflation pressure, especially usually it is under 20 to 25 centimeter of water. And then what about cricoid pressure? Routinely, we don't recommend. Okay. Why? If you're proficient and you can adequately visualize the chords, and it is cricoid pressure is routinely not recommended as per updated guidelines. Of course, within 5 minutes, it is a non-shockable rhythm is reasonable to administer the initial dose of epinephrine ASAP. For pediatric patient, in any setting, it better you administer early epinephrine within 5 minutes. Yes, how to assess the CPR quality in pediatric age group? I rather rely on invasive arterial blood pressure if you have a line, and rather rely on diastolic blood pressure to assess the CPR quality if you have an invasive line already. Yes, treating seizures, which are very common in the pediatric setup, and then it is recommended that continuous EEG monitoring is recommended to detect the seizures. In patients with persistent encephalopathy in case of pediatric age group. As well, you need to treat the non-convulsive status epilepticus, aggressively in post-stroke scenario. Septic shock, yes. Initially, we used to give 20 ml per kilo. Now it is reasonable to administer 10 ml per kilo or 20 ml per kilo in aliquots, with a frequent reassessment. You need to just rely on your clinical parameters. Either you can just see your heart rate decrease or urine output, just your response to your initial fluid boluses. Rather give IV crystalloids in a case of septic shock. Yes, fluid refractory septic shock. What is your initial, vasoactive infusion of choice? Yes, epinephrine, as we do, epinephrine or norepinephrine is the initial vasoactive infusion of choice in a case of septic shock in pediatric age group. Of course, again, refractory septic shock to your epinephrine and norepinephrine infusions. I rather go and to proceed for dopamine as a second line of agent. Okay, again, you get again unresponsive to your fluids and vasoactive support. Rather, you can just consider stress dose corticosteroids, preferably short-acting steroids at 4 mg per kilo. Pulse, again, hypotensive hemorrhagic shock. I rather rely on not IV crystalloids. You can start it off with crystalloids, but try to administer blood products. Okay, try to activate your massive hemorrhage protocol. Okay, as per your local guidelines, and just proceed. And again, opioid overdose in a pediatric age group. Just again, you can administer intramuscular or international naloxone at the earliest. Yes, another important thing, ECMO, extracorporeal life support. It is nowadays widely used. Yes, in our setups we do have this support. Yeah, and post-ROSC, or if really indicated, early consideration of ECMO or extracorporeal life support can be beneficial, for the end organ support, and as well in the initial scenario, it can prevent the cardiac arrest. Of course, you are doing CPR. Yes, early consideration of extracorporeal CPR also would be beneficial in a case of pediatric age group as well as the adults. Pulmonary hypertension, yes. Now, inhaled nitric oxide or post-cyclone is going to be beneficial with a careful respiratory management and monitoring. Quickly come to the NOLS. Yes, these guidelines just are based on the extensive evidence evaluation, which are developed in conjunction with the International Liaison Committee on Resuscitation and affiliated member councils. Yes, umbilical cord management, which is very important. You don't try to go to the peripheral IV axis or something. If you don't clamp it, basically. There are two things here related to the umbilical cord and umbilical vein axis. You just give the skin-to-skin contact with the mother after the birth. That's going to be beneficial. How? It is going to improve the breastfeeding temperature control as well as the blood glucose stability in any neonates. As well, immediately don't. After 1 minute or within a minute, you can just clamp the cord, after the birth of the baby. These are the quick steps which how we are going to do. Initially, warm is required, positioning. You need to dry, just stimulate the baby. Of course, again, your if you're having, decreased respirations, just you can provide your positive pressure ventilation by AMBU. Yes, of course, you suspect meconium stained amniotic fluid and then meconium aspiration. Just grab a laryngoscopy, okay, with a Miller blade and then just see, and you can do the ET suctioning if the obstruction is evident. As well, after that, you need to continue your PPV, and then if unresponsive, just proceed for chest compressions if failed to respond to your positive pressure ventilation. IV access, again, umbilicus venous catheterization is very easy. I assume, I recommend every emergency physician, please go to labor suit, and then how the pediatrician are doing. Just make sure that you are aware of the umbilical vein and then umbilical artery and all those. Just, it's a very simple technique. Okay, all of you can quickly learn. Okay, suppose yes, you are doing the resuscitation. How long you are going to do? After 20 minutes of resuscitation, just you can discuss with your pediatrician or neonatologist, and then you can stop the resuscitation efforts carefully. Just you need to, again, it's an emotional event, you need to involve the family. Okay, you need to explain to them why you are cessating your resuscitation efforts. Coming to education science, yes, AHA has recommended these are the training interventions which can improve your CPR skill acquisition as well as to improve your retention skills. It's a deliberative practice and mastering the learning model. Okay, as per the provider courses, you need to additional booster training. Okay, as well as you need to update yourself, as Raj said initially. And there is a space learning approach. What is this? You need to give breaks. Okay, like you have learned today something, and then give a break again, retrain it. This is space learning approach. And then CPR feedback devices, okay, to improve the CPR quality as well. In continuation to the education science, yes, teamwork and leadership training, which is very important to pick a leader. Okay, we usually ACLS or PALS instructor, generally they run the codes in our hospital. Okay, institute training is very much required. You need to be aware of the high fidelity mannequins to improve your training skills, as well as to attain the maximum knowledge of resuscitation science. Of course, gamified learning, now the sim leagues, like simulation scenarios, just you can train your residents, or you can train your physician on this. Okay, to be you need to cope up with the virtual reality scenarios to prepare for the real scenarios. And in continuation, again, for the lay rescuers, there is a self-directed CPR training. Just they can quickly go through the online modules, and then they can come for training institute to get trained for high quality CPR. Systems of care, there are two entities, like community and hospital approach. Community, yes, you can use your mobile phone. There is no need to call the numbers. Just quickly grab your mobile phone. Just make sure that you have your local emergency provider in your mobile phone, as well as your nearest tertiary care setup. And again, there should be widespread CPR training. Just you need to target the school level. Okay, they are the future generation. You need to aggressively train them for CPR. Okay, which is going to benefit the future generations. Public access defibrillation, yes, nowadays many airports, and then you can see many of the gathering areas that they have the defibrillation. Just you can just shout for tap and shout, and you can quickly ask for the defibrillator if the patient is unresponsive, or any victim if you think like is in cardiac arrest. Hospital, again, you need to plan your neuroprognostic modalities, as well as the clinical debriefing is very much important, as was stressed previously. Okay, these are the references which you can go through. Okay, thank you. Yeah.
Yeah, thank you, Dr. Suresh. That was nice, extensive, elaborative. To say frankly, it is precise and more informative. Though it is a precise, it is informative. Really, sweet and short, sir. It is very much required for each and every emergency and critical care patients. See, when we used to practice, no, in 2015, when we used to give adrenaline in case of cardiac arrest, some of the doctors, non-emergency, non-critical people, they used to fight with us. Why you are not giving atropine? There are many things what we have come across all the way. So yes, it is need of an hour. So we have to update ourselves. Suresh, anything you want to add?
Yes, sir. Yes. Okay.
Suresh sir, please drink some water.
Yeah, really, that was really very good talk, both of you, Rajkumar and Dr. Suresh. Really, both are informative talks. Then one thing. So Suresh, shall we take up the question?
Yes, sir. Yes, yes.
So there are few questions over here. I think I can take up that questions. Just hold on. So first question is, just hold on, sir. Yeah. So there is a question, interesting question. So I think it was dealt by Dr. Suresh. So, but I'm going to take up this question. So what is the double sequential defibrillation? So interesting. So Dr. Suresh, can I take with your permission?
Yeah, please, sir. I think you can.
Yeah, regarding defibrillation, I just want to tell you something before I'm talking about double sequential defibrillation. So there are three types of defibrillation. One is standard defibrillation, what we used to practice in our emergency and critical care in our hospitals. So where we can use only single defibrillator with two pads. That is standard defibrillator. So we can deliver the shock with required joules, laser joules. Then second one is vector change. It's called VC, vector change. So what we can do in vector change? So we are going to deliver shock with the same defibrillator, placing parasitic anterolateral aspects. Then second dose, we are going to change the vector from anterolateral to the anteroposterior. So pads will be changed from anterolateral to the anteroposterior. That is one kind of defibrillation. That is called vector change. Then third one, so double sequential defibrillation. So that is a new concept which is emerging from last few years. But as per our ACLS 2020, HA 2020 guidelines, there are no proven benefits with double DSD. So why? They have conducted many RCTs, ILCOR system studies. There are many studies on it. So no one is proving that double sequential defibrillation is beneficial to the patients when there is a refractory shock wave rhythms like VF, especially VF. So there are many studies on same thing, double standard defibrillation, double sequential defibrillations. So it was done on outside hospital cardiac arrest case scenarios. So there are no proven benefits with this. Then one thing I would like to add here, then how we are going to do double sequential defibrillation? Simple. So we need to have two defibrillators with the 4 pads. So one defibrillator is like a standard defibrillation, placing pads at the anterolateral aspect. Then second defibrillator with the 2 pads, placing it anteroposteriors. So we have to give successive defibrillations at the same, simultaneously. So what happens? Sometimes it may harm to the patient as well. We are delivering high voltage energy. So sometimes it may damage our defibrillators as well. So that's why as of now, so we don't have any proven beneficial effects from the sequential defibrillation, double sequential defibrillation. Suresh, anything you want to add here?
Yeah, that's it, sir. I think you have.
Rajkumar, anything you want
yes,
to add?
Yeah, just one point, sir.
Yeah.
Like you said, it's very important to make sure the company's warranty allows it. Because if you void the warranty, your hospital will not keep quiet. That is one thing. And second thing is the indication for dual sequence defibrillation is very specific. They only tell for refractory ventricular fibrillation, which means you give it 5 or 6 shocks, it's not working, then you go for dual sequence defibrillation. And they also use esmolol, which is a beta blocker IV, along with dual sequence defibrillation. So the guidelines are not very clear. There's no specified approach to dual sequence defibrillation. It will take some time, definitely. That's the only thing, sir.
Yeah. True, Suresh.
Yes.
One more question here. Is lidocaine superior to amiodarone? I think I can take this question. See, lidocaine is not superior, may or may not be superior to the amiodarone, but it is alternative to amiodarone. When I say in some areas we may not get amiodarone on time. In such scenarios, you can use lidocaine instead of amiodarone. So nothing is superior, nothing is inferior. Just lidocaine is alternative to amiodarone. Suresh, anything to add here?
Yeah, that's it, sir. I think.
Rajkumar?
Yes, sir. That's what the HSS. It's reasonable to consider lidocaine when there is no amiodarone. That's what the HSS.
So nothing is superior, nothing is inferior.
Yeah. Yes.
It is just an alternative. That's it.
Yeah.
Then one more question over here. So what are the special consideration while dealing with pregnant cardiac arrest? Even I can take this question again. Yeah. So when it comes to pregnancy, so there are many changes, physiological changes changes during pregnancy. So one is reducing in the functional residual capacity, which prone to cause hypoxia in pregnant ladies, pregnancy. Okay, so when you come across cardiac arrest in pregnancy cases, you should emphasize more on airway management, on oxygenation. So these are the two things. If you focus on mainly, then there are high likely of getting ROSC in case of maternal cardiac arrest. So two things. One is oxygenation. Another one is airway management. Then there are many updates on maternal cardiac arrest in our AHA 2020 guidelines. So one thing was, first one is, what about fetal monitoring during maternal cardiac arrest? So no. So with the recent evidences and with regard to the AHA 2020 guidelines, need not to focus on the fetal monitoring during maternal cardiac arrest scenario, because it may hamper our services what we need to be done at that point of time. So please don't focus on the fetal cardiac monitoring at the point of maternal cardiac arrest. Then what about TTM, target temperature management after ROSC in case of pregnancy? Yes, we have to do it. We have to follow the TTM, target temperature management after ROSC. But only thing is, you have to focus on fetal bradycardia when you are practicing the TTM. That is one thing. Then Suresh, sir, anything you want to add in the maternal cardiac arrest?
Maternal cardiac arrest, again, sir, there is a, as I mentioned, like you need to act quickly. You need to quickly grab the ultrasound and then just see what is the probable cause. As I mentioned, like there is a A to H causes. Immediately, I think as an emergency patient who is a code runner, they need to quickly go through the A to H quickly. Within, I think, 2 to 3 minutes, they should quickly analyze. I think in this scenario, I think if you're a junior, please involve the senior. I think that's going to help them a lot. Don't hesitate to get the senior help, and don't hesitate to get the obstetrician into picture. Okay, anesthetist, of course, it is required, but try to get the obstetrician, neonatologist, as well your senior. That is going to help 2 lives. That's what I'm saying. Yes.
Yeah, exactly, sir. Then,
and we have tackled these scenarios basically before, so that's what we have gone through these scenarios. Luckily, we have saved, I think, a few of the neonates basically. So that's what is very paramount importance, and you need to know how. You need to be familiar with the normal labor too. Yes.
So one more question over here, sir. Should fetal heart rate monitoring during maternal cardiac arrest? Same thing, Dr. Suresh, sir.
Fetal monitoring, yes. Again, as I said, like please concentrate on your resuscitation efforts. Okay, if you're grabbing the Doppler or something to look for heart rate, it's going to take some time. Please just hold it. Okay, please concentrate on your resuscitation efforts, ABCD approach, and then please, if the patient is stable, if mother is stable, yes, you can just quickly grab and then just screen the fetus for heart rate. And as well, you can just, as I said, like early involvement of obstetrician. I think they can come and help you out with those. I think your primary importance is resuscitation. Please proceed with that. That's it.
Yes, true, sir. So we focus more on maternal cardiac scenarios. So we give less importance to the fetal cardiac monitoring. Exactly, sir. Then one more question. So what is the role of ultrasound in life support? Dr. Suresh, sir.
Again, I think, yes, exactly. Over the year, like last 3 years, or even in our residency program, and we are teaching our residents how to use an ultrasound, whether it is a EFAST or whether it is a rush protocol, brew protocol, or quickly screen the lower legs for DVT. And all those, I think we need to be trained for level 1 as well as a level 2 as an emergency patient by the end of 3 years. And this is why, again, you can detect the life-threatening emergencies very quickly. Whether you can just simply ABCD, breathing, you can quickly see for tension pneumo as well. And then you can go to the heart, see the tamponade, you can see whether how is the contractility. You can quickly go down, you can assess the IVC, and then you can just screen the free fluid. In a case of trauma, that's going to have a paramount importance in treating any cardiac arrest victim. I think that's going to in turn save the life as well. Yes.
Yeah.
So there is the recommendation specifically says that do not use ultrasound for prognostication. It says use it during cardiac arrest. Use it during identifying the reversible causes, but not during prognostication. For that you have other parameters.
Yeah. Thank you, Raj. There one more question over here. Is there any harm in giving atropine with adrenaline? I think Dr. Raj can take up this question.
Raj is the correct person to take this, basically. I think he's teaching these are all over the last 5 to 10 years almost.
Yes, sir. I think usage of atropine demonstrates how AHA science has evolved. That is the best example to teach how AHA science works. So the reason atropine was removed from cardiac arrest is not because of its muscarinic effects or not because of its M2 effects or whatever. The reason atropine was removed from AHA guidelines is because it does not have any benefit. Simple. There were 2 RCTs done. Both the RCTs failed to demonstrate any benefit of atropine in cardiac arrest, nor did they demonstrate any harm. No harm, no benefit. Why complicate the algorithm? Remove it. That is a simple logic. So no harm, no benefit. We don't want to complicate the algorithm. We don't want nursing students remembering so many things already that they're struggling to remember, or BBA students trying to remember so many things. We remove atropine. That's also.
Yeah, thank you, Dr. Ras. Suresh sir, you want to take up any more questions? I think we covered most of the questions are here.
Almost 1 hour of time.
Yeah, that was a nice session. Then just to summarize all these things regarding AHA updates 2020. Just to summarize regarding BLS, ACLS, PALS and NALS. When it comes to BLS, as Dr. Suresh sir said, 6th link in chain of survival has been added. Then OPR related BLS for lay rescuers and healthcare providers. Then when it comes to cardiac arrest, more emphasis on ASAP administration of adrenaline in case of non-shockable rhythm. Then lidocaine, then AV feedback systems, then PET CO2 monitoring and arterial BPs, then no role of DSCD, dual sequential external defibrillators. Then more focus on IV rather than IO. First try to get the access of IV. Then when it comes to bradycardia and tachycardias, yes, atropine dose change from 0.5 to 1 mg. Then dopamine dose from 2 to 20 mg to 5 to 20 mics per kg per minute. Then post ROSC, neuroprognostication. They're focusing more on the neuroprognostication. It includes physiological, neurological, cardiopulmonary, and cognitive impairment before patient is going to get discharged. Then it comes to what is that pregnancy? As we discussed earlier, more focus on the metal cardiac arrest. Less focus on fetal cardiac monitoring, target temperature we have to follow. Then it comes to acute coronary syndromes. So no NSTEMI, STEMI, unstable angina. Only thing is ACS, STEMI and NSTEMI. If cath lab is ready, just bypass the ED. Same for the ACS and stroke. Then pulse when it comes to breath, 2 to 3 breaths per minute per second all. So there are a lot more changes which was happened and which was updated in our recent AHA 2020 guidelines. Please follow it. It is for our sake. It is to improve ourselves, not only to improve ourselves, but also to get good outcomes of cardiac arrest. So if you know all these things, there are high chance of getting ROSC. So please do follow. Please do update yourself. Thank you, Anandal. Thank you, Dr. Suresh. Thank you, Dr. Rajkumar.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.